upper GI registrar's work in Plymouth. I'm just coming towards the end of my MD and going back to ST8 in October. James sort of asked me about 2 months ago to talk a little bit about the FRCS Part B in terms of preparation. I've been in the Southwest since 2015, and we've had these presentations every time, and they cover quite a bit. I'm hoping to cover a little bit here. The main aspect really is to go into the practicality of the exam and what's expected of you, and the fact that, well, there's two main points really to take away. If I can pass it, anyone can, because I'm not that bright. And the second thing to say is you've been preparing for it your whole career. So I don't think you should treat it as an exam as much as the journey towards the exam, of getting involved with your colleagues that you're revising with, trying to understand sort of the MDT process when you're discussing answers with other colleagues when you're revising, because essentially that's what you're preparing for, being a consultant. So what do I mean by preparing for it? I'm just going to see if it moves for me. Has it moved to the next slide? Yes, it has now. Can you see that all right? Just checking one last time.
Yeah, it looks good, mate.
Okay, cool. So this is the journey of registrar training, in my humble opinion. I might be wrong, but it's sort of part of what I went through and the questions I've had asked from ST3 up to about now. And I think it's important to look at that slide because, you know, when I was told about it, when I was about ST4, ST5, I was told about this concept of the Dunning-Kruger effect and sort of the confidence levels you go through as a surgical trainee. And I didn't really believe it. And now, having come in towards the end of that slope, and before I start the slope again and dropping confidences, going into consultanthood and stuff, I think is very accurate and reflecting what happened to me. So if I just go through it very, very quickly in terms of actually preparing for the exam, you're going to go through that journey at some point during your training, I think. So you start your ST3, you've just got your number, you're on top of confidence, you can walk on water, anything you touch turns into gold, you're operating, you're doing operation you thought you couldn't do. That lap chole that used to look difficult when you were a CT2 is looking much easier. You know, I was in Truro at the time, and I remember just being on top of the world. Then you come to sort of ST4, and in ST4, so the period between the middle of ST4 to the end of ST5, it can happen throughout the whole period. It can happen at the beginning of that period or at the end of that period. Certain things just don't go your way. You're not getting the right answers in some questions when you've been asked by the bosses. You know, you might sometimes have a confidence crisis. Am I actually a surgeon? Am I good enough? And what's actually happening is you're realizing what awaits you in terms of your learning. And that's fine. It's okay to go through that. The most important part of it, though, is this big green bit. You need to talk to somebody about it. I certainly did when I was going through it. And I had a complete crisis in confidence at the time, thinking, you know, can't even tie a knot properly. What's going on with me? Or I can't do this part properly. And when I called the people who are ahead of me in training, they all told me about this curve, and hence why I'm telling you about it now. And then what happens is there is a point in a period where suddenly things just click. And for me, I remember it quite clearly. I was an ST5 at the BRI, and I was with Chris Streets, and Chris Streets let me do a lap chole, which was slightly more difficult than my level, but he let me crack on. And it was 5 o'clock in St. Mike's Hospital, and we worked on it till 6 o'clock, and he didn't take over. And in a way, he kind of showed faith in me. That's why Chris Streets will always be one of my heroes, because it was that, literally, that was the turning point for me, where the slope just started sliding upwards. The problem in that period of ST5 to ST6 going to ST7 is you can come across slightly arrogant. So you got to be careful because you're not a consultant yet. So be respectful when you're having discussions with bosses or having discussions with seniors about where you think you lie. And what happens is when you get to ST7 is when you're sort of let loose to do a lot of the operations by yourself. So that Hartman's, where sometimes the boss would have come in because they're happy with your surgical skill, they might not come in. And so what happens at that point is you start developing a few complications here and there. And there's a slight drop in confidence because you're now realizing that it's about to get real. You know, you're going to be a consultant at some point at the end of this training. And it's at that point that the exam comes along. And when the exam comes along, you kind of think, this is the last thing I need at that moment. But actually, it's a poignant place for it to come along, because once you overcome that journey of the exam, your confidence goes up again. And then you're ready, hopefully, for your ST8 or fellowships and going on to consultant. So looking at the exam in sort of the more detailed aspect of the exam always happens on the week. It happens on a Wednesday, Thursday, and Friday. You are either part of group 1 or you're part of group 2. Group 1 will have all of Wednesday and half of Thursday. Group 2 will have the next half of Thursday, so lunchtime Thursday to the end of Friday. And the whole day is usually for the vivas. And so the whole day actually starts at sort of 7:30 in the morning and finishes sometimes for some people at 6 o'clock in the evening. But as you can see from all of the numbers I've written here on the slide, it's only at 2 hours of being tested, really. And so you feel like you're almost in an athletic meet. Essentially, you go in for half an hour, you get asked the questions, you come out, you sort of relax for about an hour to 2 hours, and then you go back in again. So just a few things to cover with the station. So there's a speciality. You get 6 stations. Each one is 5 minutes, and it is 5 scenarios where you've been asked questions. You get a critical care and emergency, and that can range from trauma aspects to questioning aspects such as diabetes in surgery, jaundice in surgery. And then you get a general surgery station, and that general surgery station can generalize from talking about things like hydrocele, which is more of a urological thing, but it's considered under general surgery, to aspects such as fitness. How do you test for fitness for someone who's about to have a AAA repair? And you have to discuss that over 5 minutes with the questions they're throwing at you. Then you have an academic paper. In terms of the academic paper, you get 30 minutes to read it. Actually, it turns out to be longer because by the time you get to your station, it takes a while. And then that academic paper station, you get essentially two areas. One of them is a paper analysis, so the paper you read and you go through it. And the last bit is the basic sciences, which is usually on your speciality, where you get asked 3 5-minute questions or 3 stations and you talk about it. So for example, I'm upper GI OG. So I had a bile leak and we're discussing the anatomy of the biliary tree. I had dumping syndrome. So we're discussing the physiology of dumping syndrome after an upper GI procedure. And I had a bypass station. So in bypass, I was asked, can you draw the anatomy of a bypass? Let's talk about complications of a bypass using that anatomy. So it's not stuff you haven't covered before if you've revised with others. The important aspect to remember is that it is 5 minutes, so you got to get there. And hopefully when I cover the next bit of the presentation, I'll explain how you can get through that 5 minutes quicker. The half day is usually the clinical day, and having experienced it myself and having spoken to a lot of my colleagues who have done it and who I've revised with after my exam and who've done it, up to the ones who've done it 2 weeks ago, is divided into really a speciality and obviously the general. And each one you get 3 stations essentially. So a long case, which takes 20 minutes, and 2 short cases. So for example, in my long case for my speciality, which is OG cancer, I had an esophageal cancer that was a squamous cell, and we discussed it. Long case for the general for me was a lady who came in with a femoral hernia. And it involves taking a history, doing the examination, and actually doing it properly and doing it in a lot of detail. For example, the lady that had the femoral hernia for me was on a NOAC, was frail, and so you had to discuss her social situation. And it's in that clinical station where they can ask you, for example, consent for a femoral hernia, consent for an ERCP, and it's actually testing your clinical skills. The most important aspect to remember is take your time asking the smallest questions in the clinical station. They will rush you through to get you to where they want you to get to, but they will mark you. Don't miss things like allergies, because my lady was allergic to penicillin. So when we discussed antibiotics as part of the surgical procedure, I explained because she's penicillin allergic, we're not going to give her any penicillin, and so forth. So like I said, it feels like an athletic meet. You go in, you're thinking it's going to be a dark swim. It's very cloudy. What on earth is going on? And actually, there is a light at the end of the tunnel. At the other side of the island, there is some light. The important aspect is it's not about the destination, it's about the journey. And this is what they're testing. They're testing your understanding of having to work with other consultants. And the way to do that is by revising with other registrars going through the exam. I cannot emphasize that enough. You've been revising for this your whole career. An example I can give which reminded me of my SHO days, I was asked about compartment syndrome. I had an anterior resection patient, and the anterior resection patient is woken up day 1 post-op with significant left leg pain. How are you going to approach this patient? Straight away, I had a something come to me in my head about a urologist when I was a CT that used to had like 3 compartment syndromes in some of his patients. And for some strange reason that came to my head and I went, oh, good Lord, this patient's got compartment syndrome because it's too early for a DVT. It's only day 1. And so you kind of get excited because you know the answer. And what you need to be able to do is the expectation as an SHO and as a registrar is, yes, I know the answer. I know what the correct answer is. But the exam is not testing that. The exam is testing how you're going to approach it as a consultant. So I knew at that moment I'm dealing with compartment syndrome. So I thought, he said, what is your differential diagnosis? So my answer, I sort of backed up a bit and I went, well, this is a patient who is a cancer patient, and we know they're prothrombotic, and therefore, if they've been immobile before surgery, DVT and PE will be high on my differential diagnosis. Now, I know it isn't, and the examiner knows it isn't, but by approaching it like this, I have shown him 3 things. Number 1, I'm looking at the patient and visualizing them. Number 2, I have appreciated that PEs and DVTs are more common than compartment syndrome. And number 3, I am looking globally at the patient. Now, for those of you who live in Plymouth, this is the Royal William Yard. So you can take a really nice photo of the Royal William Yard with the sun shining on it. But those of you who live in Plymouth know that that's only the ground level view. However, if you take a drone view, you see the whole building and how big the structure is. And that's kind of the exam. You're going from very simple history and examination questions to transfer into a global view where you're involving other specialities and other expertise. And it is that journey that they're testing. And you can only get that journey right if you practice with others. And by practicing with others, you identify your areas of weaknesses. You are practicing to be a consultant, because every consultant at the moment discusses their patients in MDTs or with their colleagues, especially difficult patients. And they will test that. That's part of their testing. So let's look at the exam in a practical point of view. So we're talking about the ground level view and the drone view, if you like. So looking at it from a ground level view, if I'm about to take a history and an examination, be it on a Viva or on a clinical station, one of the mental things I always try and teach those who've done the exam that I've taught or to go through with myself is think of your happy place. What do I mean by think of your happy place? Think of the place where you enjoy doing that activity. So for example, if there is an emergency resus patient, I always imagine myself in the Derriford A&E. I'm not sure that's my happy place, but the reason I imagine it there is because I know CT is right next to it. So that way I never forget to get the CT and I can tell how easy it is to do a CT. Second thing, I had another station where a patient had a groin abscess. The registrar had carried out the incision and drainage and blood was everywhere. So you are the consultant. What are you going to do? Straight away, I imagine myself in Derriford, again, on the 7th floor where the registrar office is. And you guys know where we are, those of you who work there. And I basically said, I will tell my registrar to put their finger on the pulse, so hold everything together while I come down the stairs. And I then went through the journey of coming down the stairs down to level 4. I'm entering theatre. And as I'm entering theatre, I'm seeing everyone. So where the duty anaesthetist would be, where the sister would be, where the person in charge of theatres would be. And as I'm going through that journey, before I get to theatre 7, where surgery is, I've already considered all of these questions. So when I answered the question, it wasn't just, oh, let me just take over. I said, I'll speak to sister to get the duty anaesthetist in, because this might just be a registrar doing the operation. I will make sure that the massive transfusion protocol is kicked off. I'm going to do all of these things even before I've even reached the patient. So that's one way of my happy place, or a place that I'm used to can help. From a clinical point of view, from a clinic's point of view, I used to do a lot in the BRI. I used to be in Andy Hollowood's Thursday clinic in South Bristol. It was a big room. There's a big computer. You always had the sheet with the BMI written on the top left corner. So that way, when I'm doing a clinic, I always don't forget to ask about BMI. You always walk the patients in from the waiting room. So that way I can test the frailty of that patient, XYZ. So it's important to think of somewhere you're used to when you're doing the exam. So coming to the ground level and asking questions in history and examination, the three areas that the exam really is starting to focus on now is cancer, fitness and frailty, and nutrition. They will be repeated again and again and again in your station somehow. And they will be intertwined together. For example, in a general surgery station, even if you're not an upper GI surgeon, you will be asked about gastric cancer. They will ask you about the management of gastric cancer, and you're expected to know a bit about it. And it's obviously in terms of appreciating the involvement of the MDT, centralizing to the patient, making sure the family is aware of what's going on, the patient is aware of what's going on, planning what to do with that patient. But then they'll say to you, the gastric cancer has now developed an inguinal hernia and their life expectancy, and they've got ascites. Are you going to operate on that hernia? Now, there might be a simple no, or if you're really brave, you might be a big yes. But that's not the answer. The answer is about considering the patient, considering their symptoms, discussing the risks and benefit with the patient, discussing it with other colleagues, and then coming up with an MDT decision, discussing it with the oncologist looking after that patient. So again, it's that drone view of what's going on. I'm not going to go through alarm symptoms and cancer because I think you guys are at a level that know all of it. Nutrition, keep it simple. Are they able to eat and drink? Do they need to be admitted? And you need to be very clear about that, especially if it's an upper GI station. Someone's got difficulty swallowing, who's got significant reflux, and you're wondering about cancer. If they have got an obstructed cancer, you need to bring them in to be admitted for nutrition. That patient who's a Crohn's patient, who is cachectic in front of you, who will need a right hemicolectomy at some point, you are not going to do an anastomosis if their albumin is 12. You are going to take them in, you're going to give them TPN, you're going to feed them up, you're going to get the gastroenterologist involved. So nutrition plays a part, whether it's colorectal or whether it's upper GI, whether it's cancer or whether it's benign. If you're going to operate on someone, you can't operate on them without knowing their nutrition status. Most importantly, you won't be operating on anyone without knowing their BMI. So make sure that BMI is also at the top of your list. It will actually change what operation you do in some cases. In upper GI, for example, if someone's got a BMI of less than 30 and they've got reflux and you've proven it, you do a GORD operation such as fundoplication. We know for a fact if they're over 35, that operation doesn't work. And you will be tested on that as an upper GI trainee. Fitness and frailty is massive. They love talking about it. They love discussing it. My station, my general surgery station was, you've got a 75-year-old with a 7 centimeter aneurysm, and they have come to your clinic and referred as urgent to be operated on. Can you please assess their fitness? And I went through it from walking them into the consultation room to taking a good history about whether they can go up the stairs or not. How are they going from the car to the front of the store? Do they get? And then I talked about the Rockwood score in terms of their frailty. This is a very good picture to discuss when answering questions in the exam, because the expectation is if you learn this by heart, you will look impressive. So you can say, well, it ranges. There's very fit, which is level 1. There is well, there's managing well, there's vulnerable, and you sound more like an SHO and a registrar. If you want to sound like a consultant, you could say the Rockwood score is a score, and I basically pretended when I was in colorectal, because we used to use it a lot in colorectal, where in clinics I've worked on, we have a picture shown going from very fit at 1 to terminally ill at 9, and we assess the frailty of the patient according to the pictures and to the terminology in that chart. That is the same answer as going through the whole thing. They don't expect you to know the whole thing. Geriatricians don't know this by heart. That's why there's leaflets in clinic. So it's important to take your time when answering. You are answering it like a consultant. You have to be slightly overconfident about your ability just to show you're a consultant, but just humble enough to say, I'm a day 1 consultant, so I'm not going to be doing anything too heroic. I'm going to just be sensible. The other pitfall that a lot of people have fallen in with is the concept of preparation for the patient. So one of the guys I revised with had not passed his exam the first time round, and one of the stations he didn't pass was a reflux station. And actually, it was an easy station where he mentioned all the things you need to mention. And when he looked at his feedback, the feedback from the examiner was taken to surgery too quickly. And essentially, The workup is very important in the elective setting. In an emergency setting, I understand you could have a patient that's dying in front of you and need to take them to theatre straight away. But in an elective setting, you have got time, if the operation is not life-saving, to work them up properly. So make sure you do that. So if you've got a benign patient who's not got an operation that needs to happen really, really quickly, if you haven't said the word clinic 2 or 3 times, you're rushing too quickly to surgery. So take your time in talking about that. When it comes to treatment, please be sure that you cover all aspects of treatment to individualize the patient. There's no point of saying that I've got a bariatric patient who I'm offering a bypass. How are you going to treat it? I can say bypass. That's a good enough answer. That will get me a pass. But in order for it to be a high pass, what you can say is, I need to check if she's smoking or not, because if she's smoking, I need her to stop smoking because I know that there'll be ulcers in my anastomosis if she does. Can she psychologically show that she is actually working with the tier 3 and tier 4 weight management program? Are the nurses and the dietitians happy with her? That's all part of the management. Medically, how is she doing? How is her sugar control? Is it bad? Is it good? What's going on regarding that? There's nothing obviously you can do endoscopically or endoscopically for bariatric surgery unless you're talking about really complex bariatric surgeons, but I'm not going to cover that today. And then you go to the surgery. Same thing with an emergency patient. My lady who had a femoral hernia, I took at the theatre, but I didn't forget about my nil by mouth, putting an NG in, putting a catheter in, giving her fluids. Now that might all sound non-consultant like answers, but actually that's very important, because if you haven't put an NG in and then she's anaesthetized and then she starts vomiting while being anaesthetized and gets an aspiration pneumonia, your femoral hernia operation ain't going to work. Now, you and I know this, but when you get to the exam, you kind of clench up. And so what happens is when you're revising with others, make sure you always just have that chart in front of you. What can they do about their lifestyle? What can I do conservatively? What can I do medically? Is there anything radiological I can do? Or should I go straight to surgery? So that's the important aspect and the important question to ask. I've shown this slide last year. As I was showing the chart between ST3 to ST8 that I showed at the beginning of this presentation, when you're an ST4 questioning, am I doing the right thing? To think about the exam at that time will be overwhelming. And a lot of people at the time go, oh, you need to think about the exam. You need to go and buy, all of the books that are teaching about the exam. All of them will be out of date by the time you come to your exam. I'm telling you that much because I fell through the same mistake. Don't overwhelm yourself. But how can you prepare practically? Well, if you're an ST3 and ST4, and I try and encourage everyone that I work with at that level, make sure you're reading the CTs that are being reported. Go and look at the images. Can you identify the appendicitis? Can you identify where the cancer is, that obstruction? And the way I used to do it, and I only started this as ST5, I wish I started earlier, is I'll look at the scan, I'll come up with the diagnosis, I'll look at the report, then I'll look at the scan again. And actually, when it came to the exam, I must have looked through about 30 slides of scans and MRIs and stuff. But because I'd already practiced on my sort of day-to-day, it didn't feel strange. Second thing is papers. Now, you don't have to read every single paper in the world, but just be sort of aware that if there's a topic you don't understand, go and read a paper on it. The example I gave last year, and I'll give this year on this presentation, is when I was an ST5 with Paul Wilkerson, he asked me about dumping syndrome, and I couldn't answer the question about dumping syndrome. I went and read the paper about it. Dumping syndrome came up on my exam. And because I read that paper, I knew what was going on. I could discuss it in detail with the examiner. So make sure you are reading papers as you go along on your training, especially the salient papers for your speciality. Also, the papers for your other non-specialities. If I'm an upper GI trainee, I did my colorectal job just before I did my FRCS, and I knew there was going to be a lot of colorectal. Now, I happened to be lucky because the guy that I was working with when I was in ST6 was Mark Taylor, for those of you who know him. He got the gold medal, right? So with Mark Taylor, I just sat with him one afternoon. I said, mate, can we just go through all the salient papers for colorectal? So we went from the Mercury paper. We spoke about HEALED and how HEALED changed the game for rectal cancer surgery. And I didn't have to know it in detail, but it was just there on the background. So it can just feed that discussion. Why is that important, keeping up to date with papers? It's not because you're going to mention them on the exam, because you might not get asked about them, but just in case it gets dropped. So when we did our exam, one of the main things that came out was the HALT-IT trial, for those of you who know about it, which is looking at it's essentially the crash trial for PR bleeding, isn't it? Where they're looking at tranexamic acid and whether they affected mortality or not. And I had a PR bleed, went through the ABCs, and she said, great. And the examiner just said, so are you gonna give her tranexamic acid? And I went, no. And she said, why not? And she pushed me onto that. And I pushed back and I said, well, the HALT-IT trial has just come out 2 months ago, and it shows that there's an increased risk of DVT and PE, but there's no change between mortality. And then she made a document in her notes, which I think it was a mark. So being on touch with papers, you don't have to be absolutely knowledgeable about them, but just be able to discuss them openly in terms of your clinical practice. So the takeaway message really is you've got to have a drone view of what's going on. You've got to be safe, you've got to be sensible, and you've got to be structured. Now, that sensible part includes being able to defend your ground. And what do I mean by that? So I'll give an example. I had a patient on my short case clinical station who had a right upper quadrant mass. Now, in my head, I was thinking, is this cancer? So I went through all the questions about cancer, and there was no evidence of any alarm symptoms. I then was thinking about my differential diagnosis during the examination. I went, this could be a hepatic cyst, because I know from my revision with Mr. Aruri here and with a lot of the guys that hepatic cysts are very common in the upper GI station. So I said, I will then proceed to examine the abdomen, examine for any masses, and I will pull up the kidneys. Now, he said, why the hell would you pull up the kidneys? And had a go at me. The examiner had a go at me and said, why would you pull up the kidneys? Do you ever pull up the kidneys? Now, I remembered, and this is what I'm saying, you're preparing your whole career. I was a medical student. And when I was a medical student, I gave a presentation on polycystic kidney disease. And polycystic kidney disease associated with hepatic cyst. And that came to my head at that moment. Don't know why, but it did. So I said, of course I'll pull up the kidneys, because she could have polycystic kidney disease, and this is a hepatic cyst. Secondary to that, we then proceed onto the station where he shows me the images. So he shows me the image of the CT scan. Patient's got a massive hepatic cyst. He then shows me another slide which has nothing to do with the liver that shows a massive renal cyst. So the patient did have polycystic kidney disease. Now, he was being argumentative to see if I stood my ground or not. I'm not saying be rude, but be very sensible and defend your ground, because ultimately you are their colleague for that exam. You are more junior than they are, but you are at the same level in terms of this is to test whether you're ready to be a consultant or not. I hope that was helpful, that I covered a few points that might be useful for those of you about to sit the exam. And I'm obviously more than happy to help and chat with if you want to email or what have you. Any questions?
That was brilliant, Mo. Thanks for that.
Pleasure.
I've got a question. So the long cases, are they sort of with a patient or an actor?
So when I was the first group to do it after COVID, when I did it in November 20. But they are bringing patients back. So the last exam that Emma, Phil, and Pete just sat, they had patients for the long case. So they're going to start bringing patients back more and more. They will let you know beforehand. But yeah, patients are coming back to the exam now because we're over the COVID period. But during our one, we didn't have any patients.
Okay, nice.